Hey everyone, welcome back to The Explainer. Today we're diving into a fascinating piece of human biological engineering that, frankly, causes a lot of us quite a bit of grief. Have you ever wondered why a simple cold can just suddenly turn into an absolutely agonizing earache? Or why flying on an airplane can leave you temporarily deafened? Well, today we're going to unmask the main culprit behind all these painful problems. We're looking deep into the mechanics of the middle ear, and specifically the unsung and, let's be honest, often malfunctioning hero of our skull, the eustachian tube.
Here's our roadmap for today's explainer. 1. Anatomy of an earache. 2. 5 stages of infection. 3. The antibiotic arsenal. 4. Unsticking glue ear. And finally, 5. Surviving airplane ear. Okay, let's dive right in.
Starting off with Section 1, Anatomy of an Earache, the eustachian tube breakdown.
To really grasp what goes wrong in the ear, we gotta start with the biological plumbing. You know, the ear isn't just some sealed drum on the side of your head. It's actually deeply connected to your throat. And that connection brings us to our first real villain today. In the medical literature, it's called acute suppurative otitis media, or ASOM for short. Let's translate that jargon though. Basically, this is an acute, sudden inflammation of the middle ear caused by pyogenic, or pus-forming, bacteria. And here's the kicker. It almost always follows a simple viral infection of your upper respiratory tract. So you catch a common cold, your defenses drop, and these pus-forming organisms just use your internal plumbing to march right up into your middle ear.
Now, if you're a parent, you know all too well that infants and young children get these ear infections constantly. But why is that? Well, it literally comes down to a sheer anatomical disadvantage. In a young child, the eustachian tube, that little passageway connecting the back of the throat to the middle ear, it's shorter, it's wider, and it sits far more horizontally than it does in an adult. It's essentially a straight, wide-open highway for bacteria. This is exactly why breast or bottle feeding an infant while they're lying completely flat can actually force milk and bacteria straight up into the middle ear.
Moving on to Section 2, 5 stages of infection, the escalation.
So, the bacteria have breached the gates. They're in the middle ear. What happens next? Well, the medical text lays out a very clear escalating war inside your skull. It runs through 5 specific stages. It starts off simply with Step 1, tubal occlusion. Basically, the eustachian tube swells shut from the cold. Because it's closed off, the middle ear absorbs the trapped air, and that creates a negative vacuum pressure. Then we move to Step 2, presuppuration. This is where the bacteria start invading the cavity, causing redness and congestion. Fluids start to appear, but it's Step 3 where things really reach a boiling point.
Now, what's really interesting about this next phase, stage 3, suppuration, are the sheer physical mechanics of it. At this point, the bacteria are rapidly multiplying and pus is forming. But remember, the tube to the throat is completely swollen shut, so this pus is trapped under immense pressure inside a tiny bony cavity. This causes the eardrum, the tympanic membrane, to literally start bulging outwards. The symptoms here are severe. We're talking an excruciating earache, temporary deafness, a high fever spiking up to 102 or 103 degrees Fahrenheit, and extreme restlessness. If a doctor looks inside the ear at this stage, the eardrum looks angry and red with a distinct yellow spot right where the pus is threatening to rupture through. If this infection isn't stopped, it progresses to either stage 4, resolution, where the eardrum might actually rupture to let the pus out, which suddenly relieves the pain, or, much worse, stage 5, complication, where the infection can actually spread to the brain or facial nerves.
Which brings us to Section 3, the antibiotic arsenal, fighting back. To prevent those severe complications, we enter the medical detective phase. Doctors absolutely do not mess around with ASOM. Antibacterial therapy is immediately indicated for cases with fever and severe earaches. The most common bacterial culprits here are Streptococcus pneumoniae and H. influenzae. The go-to treatments? Antibiotics like amoxicillin or ampicillin. Now here is a massively important detail from the text. Antibacterial therapy must be continued for a minimum of 10 days. Even if the pain completely vanishes on day 3, stopping early can lead to a sneaky chronic condition and permanent residual hearing loss.
But, antibiotics take time to kill the bacteria. What about that agonizing pressure happening right now? Well, alongside the antibiotics, doctors deploy a support arsenal. They use decongestant nasal drops and oral decongestants. Why? To attack the root cause. The whole goal is to reduce the swelling in the eustachian tube so it can finally open up and let that trapped pus drain out naturally. Add in some paracetamol for the fever and pain, and maybe some dry local heat, and you've got a comprehensive strategy to win this war.
All right, Section 4, unsticking glue ear. the silent sequelae. But what happens when that dramatic, fiery infection of ASOM is gone, but the plumbing still isn't working right? Or what if fluid gets trapped without a massive bacterial party in the first place? I want to clearly contrast these two conditions because it is mind-blowing how different they are, even though they happen in the exact same tiny space. On the left, we have what we just talked about, ASOM. It's violent, acute, excruciatingly painful, full of active bacteria and high fevers. But on the right, we have OME, commonly known as glue ear. Glue ear is sneaky. It is insidious. It's often completely painless. The fluid inside the ear is mostly sterile, so no active raging infection, but it is incredibly thick and sticky. And, worst of all, it causes silent hearing loss. The formal definition of glue ear is otitis media with effusion. It's the accumulation of non-purulent, meaning no pus, thick, viscid fluid in the middle ear cleft. Because it mostly affects kids between 5 and 8 years old, and because it literally doesn't hurt, it often goes entirely unnoticed by parents. The presenting symptom is usually just a mild hearing loss, which unfortunately can lead to delayed or defective speech development in kids simply because they can't properly hear the world around them. And the root cause? Once again, our main character, a malfunctioning eustachian tube failing to drain the middle ear. If you look at the clinical images from the source material here, it's absolutely fascinating. You're essentially looking through an instrument right at a patient's eardrum. You can actually see the fluid level and these distinct air bubbles trapped right behind the transparent tympanic membrane. Those bubbles are just suspended in that thick fluid. This physical glue heavily restricts the eardrum's ability to vibrate, and that is the exact mechanical reason behind the conductive hearing loss. So how exactly do we get the glue out if the tube just won't work? The medical solution is some incredibly clever surgical engineering. First, a surgeon performs a myringotomy, making tiny, precise incisions directly into the eardrum to physically vacuum out that thick mucus. But to stop the fluid from just building up again the very next day, they do something brilliant. They insert a tiny hollow shape memory tube called a grommet right into the incision. It basically works on a beer can principle, providing a secondary ventilation hole to constantly aerate the middle ear from the outside until the eustachian tube finally recovers. And finally, Section 5, Surviving Airplane Ear, Otic Barotrauma. All right, so we've covered bacterial sieges and sticky glue traps. Now let's move to our final, highly relatable topic. Let's apply our deep knowledge of the eustachian tube to the sheer pain of commercial flying. So, the crucial point here is this. Airplane ear, medically known as aero-otitis media or otitic barotrauma, is not an infection. It is purely a mechanical pressure failure. It happens when the eustachian tube fails to maintain middle ear pressure at the ambient atmospheric level, specifically during a rapid descent in an aircraft, or even during underwater diving. The physics of this are staggering, and it all revolves around this number right here, 90. When you fly high, the pressure in the cabin drops, and the air in your ear expands and easily escapes out the throat. No problem at all, right? But when the plane descends, cabin pressure rises fast. If your eustachian tube doesn't open to let that high-pressure air in, a vacuum builds in your ear. According to the medical text, once that pressure difference hits a critical level of 90 millimeters of mercury, the soft tissues of your eustachian tube are forcefully sucked inward. The tube becomes completely locked. No matter how hard you yawn or swallow, at 90 millimeters of mercury, normal muscle action simply cannot overcome the vacuum to open the tube. And that's a huge problem, because once it locks, the negative pressure pulls violently on your eardrum, causing severe earache, temporary deafness, and sometimes even bleeding behind the eardrum. To prevent hitting that 90-millimeter locking point, the medical text gives us a strict prevention protocol. First, avoid flying with a cold. If the tube is already swollen, you're just asking for trouble. Second, you must actively force the tube open repeatedly during the descent, before the pressure builds up. You do this by swallowing, sucking on sweets, or chewing gum. Crucially, never permit sleep during descent because we don't swallow as much when we're asleep. And if needed, perform the Valsalva maneuver, pinching your nose and gently blowing out to auto-inflate the tube. This whole thing brilliantly illustrates just how interconnected our anatomy really is. That tiny tube connecting your throat to your ear is the absolute master of your auditory comfort. So knowing the delicate pressure mechanics of the eustachian tube and what happens when it gets blocked by a cold or locked by a rapidly descending cabin, how will you prepare to protect your hearing on your next flight? It definitely makes you appreciate the incredible yet fragile engineering of the human ear. Thank you so much for joining me on this deep dive into middle ear disorders. I hope you found this explainer as fascinating as I did. Stay curious, and I'll catch you on the next one.